All right, well, good morning, everybody. I think we're going to go ahead and get started here. We got a lot of good cases to look at today, and we're going to talk about sweat gland neoplasms. So just like all the other cases, these are new to me. I'm just looking at them the first time you are. I want to try to make this simple for you. Basically, when you think about this, these things were named, many of them, many years ago, and they've got these funny names associated with them, things like Syringoma, Spironoma, things like that. Mainly, we just want to talk about the major patterns, what they look like, benign versus malignant in the case. And then after that, that's pretty much 90% of what you need to know. So I don't want you to think you need to become a dermatopathologist or an expert and learn about all these arcane and bizarre names. I'm going to try to give you just some general pearls that you can remember. And then hopefully when you face these on a board examination, they'll seem like just pretty simple things to diagnose. So the first one here is, you can see it's a cyst, low magnification. And like all cysts, we always want to look and see what the lining of the cyst is, the lining of the cyst wall, so we can make a diagnosis. And here you can see that there is extensive apocrine decapitation secretion. Okay, so remember there's three main types of secretion that we have in the skin. We have holocrine secretion, sebaceous glands, where they just kind of dump everything into the sebaceous, into their secretion. The cells die and everything kind of gets dumped in there. We have equine, which is basically a ATP-mediated process that requires energy, and basically the sweat basically gets into the equine gland, and then the ATP clear staining PAS positive glycogen rich cells actively reabsorb the ions, so you don't lose all of your salt. So it's basically an active process to thermoregulate yourself, but also helps with preservation of ions and salt and sodium potassium metabolism. And then this last form is apocrine, and that's basically also known as decapitation secretion. So if you see this, where you get the actual little snouts, the little buds of the cytoplasm kind of get pinched off the top, kind of like a lava lamp, you're looking at apocrine secretion. So if you see this, by definition, you got apocrine differentiation. Now, the thing is, when you think about it, go back in the embryo and the way that apocrine glands form, they form from a primitive primordial stem cell area where the hair follicle and the apocrine gland and the sebaceous glands all sort of arise from that same area. Equine glands come from a different type of stem cell, so you usually don't see combinations of equine and apocrine, but you very commonly do see combinations of sebaceous and apocrine and follicular and apocrine. So that's one of the reasons why I'm not a huge fan of trying to come up with names for all these things. I mean, maybe that's a sebaceous cell there. I don't know. Kind of looks like it. And these are obviously the stem cells that are associated with it. But this is an example of a cyst lined by apocrine epithelium. So what are we going to call something like this? Well, if it's a cyst with sweat differentiation, we call it a hydrocystoma, and that's spelled H-I-D. HID, H-I-D, is the stem, the Greek word for sweat. So we're talking about hydratanoma, we're talking about sweat gland tumors, as opposed to H-Y-D, like dishydrosis, which is basically has to do with water. So this is more sweat. The other has to do with water. So this is an apocrine hydrocystoma. Totally benign lesion, obviously. Most hydrocystomas that we see kind of look like they have, they don't have this obvious apocrine differentiation. And so we may be calling those equine hydrocystomas. Don't make a big deal out of that. But basically, this is an example of an apocrine hydrocystoma. Okay, totally benign. All right, this is a shave biopsy. And you can see it's got this verrucous epithelial hyperplasia. So you can imagine what this lesion looked like clinically. Probably looked like a wart, or maybe like some kind of a seborrheic keratosis or something like that. But this lesion, as opposed to those, was probably moist. Might have been draining something on the surface, because you can see that it's contiguous with the epidermis. And it's also, once again, lined by this apocrine epithelium. Got the little decapitation secretion here. So whenever you see a verrucous epithelial lesion that's kind of got an exoenophytic architecture, like you see here, it's lined by apocrine epithelium, like you see here. This diagnosis is Syringocystinovapoliphera papillifera. Okay, Syringocystinovapoliphera papillifera. And these lesions usually look kind of like warts. They can look like verrucous lesions. They're very commonly associated with nevus sebaceous. They don't have to be, but the most common setting where we do see these lesions is in nevus sebaceous. And depending on who you read, this is the most common apocrine or most common adnexal neoplasm associated with nevus sebaceous. Some people say, well, maybe it's really a trichoblastoma. Other people have said there are a few other things, but this is a very common lesion that's seen in association with nevus sebaceous. Lesions are almost always benign, so they very rarely can become malignant. We don't usually routinely recommend re-excision of them. Occasionally, you'll see some cells floating freely within the lumen, like you see here. You may see a few plasma cells in the center of the little epithelial aggregations in here. We're going to talk about that later on, possibly. Yeah, we are. In the next case, we're actually going to talk about it because there's a simulator of this that we see that's got a lot of plasma cells in it, and it's associated in a different location. These lesions are most commonly seen on the head and neck area and the scalp. Okay. And another name, if you want to get into knowing sort of esoteric arcane information, these used to be called Werther's nevus, W-E-R-T-H-E-R, years ago. So that's just another name for this lesion, and the vast majority of these we see are seen in association with nevus sebaceous. So warty lesion, apocrine differentiation, kind of an exoenophytic architecture, contiguous to the epidermis, Syringocystinovapoliphera. Now, what if you see something that looks the same morphology in a different location, but no contiguity with the epidermis? So if you saw high magnification of this, you'd say, you know, that actually could be a nevus or a Syringocystinovapoliphera papillifera. But notice we're not sitting on the, we're not contiguous with the epidermis here. We're down in the dermis. And there's maybe some smooth muscle bundles here. There's some benign apocrine cells over here, so like apocrine sweat glands. This may be from an area, say, such as near the genitalia. And this looks almost like a cyst. And these usually are submitted as rule out cyst, rule out some kind of a dermal neoplasm, if you will. And this is an example of a Hydratanoma papillifera. So we've got the Syringocystinovapoliphera papillifera, which means it's papillomatous. And it actually, in this case, it's papillomatous probably because of these little papillae down here in the dermis. But it's this is basically the same type of lesion in a genital area with no contiguity with the epidermis. So again, you see the nice apocrine decapitation secretion here. So this is Hydratanoma papillifera. And these commonly do have aggregations of plasma cells within the area. I don't really see as many in this example, but that's something that's helpful if you see that. So Hydratanoma papillifera, another, just so think of it, benign adnexal neoplasm, apocrine differentiation. So always look at the center of the area to see what kind of differentiation you're exhibiting. Look for the apocrine differentiation here. And this lesion is generally not contiguous with the epidermis, usually seen in a general area. And there may be some lymphocytes and plasma cells up in this area over here. So that's the infiltrate that's commonly seen with it. So simple, right? You know, this isn't a difficult, challenging field. You just kind of have to think of it logically. So it looks like, so again, hid, sweat, adenoma. Adeno means gland, and adenoma means benign tumor of glands with glandular differentiation. So hydratanoma, and then papillifera, papillomatous, a little papillae associated with it. Okay, the next one, another adnexal neoplasm. And again, I don't want you to like go crazy over the names because a lot of these things, they just don't totally always read the textbook. But when we see something, you know, like this, again, this is again a benign adnexal neoplasm. It's got areas, if you took away all this kind of stuff over here, you'd notice that it looks kind of like a cyst, okay? And then you've got these little papillomatous areas in it centrally, okay? And some of these, again, are lined by apocrine cells. And, you know, And I don't like to get into a debate. You know, my old boss, Dr. Ackerman, years ago used to fight vigorously over whether something was apocrine or equine differentiation. And I personally used to sort of roll my eyes, think, who cares? You know, we really mainly care if it was benign or malignant. And I guess if you don't have anything better to do, you can argue about things like this, but we don't really care that much. We want to know whether it's benign or malignant, what kind of differentiation it's exhibiting. And then if you want to try to, you know, worry yourself sick about giving it a name, you can think about some logical ways to name this. So it's basically got a cystic area to it. It's got this ductal papillomatous area to it. So I would probably call this a papillated, the papillae, apocrine, it's lined by apocrine differentiation in a number of areas over here. Cyst, because it's got a cystic component to it. Adenoma. Okay, so it's got the adenomatous component, it's got the Apocrine Hydrocystoma component to it, and it's papillated. So I would probably call this a papillated apocrine cystadenoma. So again, it's not that hard to name if you just kind of think of it, put two and two together. If you know what and this is where etymology helps you, not entomology, studied insects, but etymology, the study of words. So if you understand the origin of what these various things mean, you can kind of put two and two together and logically figure it out instead of trying to memorize it. And I can just tell you, having memorized many, many things, and it's good mental exercise to do that, you will forget things that you memorize. You know, the half-life of a memory, if it's just basically a random memory, is pretty low. It's not going to be hanging around that long. If you put an association with it, it may be longer. But if you understand it and you have a system that you can actually use, you don't have to memorize much of anything. So you just memorize a few things, like hydra means sweat. Adenoma means basically a benign neoplasm of glands with glandular differentiation. And then if you start saying, well, is this thing cystic? Yeah, it's got a cystic component to it. Is it got a adenomatous component to it? Yeah. So you can say, is it papillomatous? Yeah, so papillated apocrine cystadenoma. And you can just name it yourself. So you don't have to worry about what it is. You can kind of figure out by using your criteria to give it actually a name that if you look at it on a multiple choice or something like that, you can actually get the answer right on a board examination. It's totally benign, vertically oriented, well circumscribed, so we don't have to worry about this being malignant or anything. So basically papillated apocrine cystadenoma, another example of a benign adnexal neoplasm. Now, this lesion, again, and these are all kind of analogous. We've kind of got them lumped together because they all kind of are differentiating in a similar sort of fashion. Notice this lesion is deep, okay? So it's down in the lower part of the dermis. And this came, you can't really tell from here, but I'm going to tell you that this came from the nipple of a woman, okay? And notice, if you go to higher magnification, it's got that same kind of differentiation that we've seen before. Apocrine differentiation up here. There's some snouting. Here you see some examples of that again over here. Nice example. And it's got a papillomatous component to it. And in some areas, it's even got a solid component to it. Would you call this a papillated apocrine cystadenoma? Well, you might, but when it occurs on the nipple like this, we call it a nipple adenoma. And there's a condition known as erosive adenomatosis of the nipple, presents usually as a reddish, kind of friable verrucous area. And this is, again, an apocrine lesion. And if you think about the breast tissue, it's basically just a gargantuan apocrine gland. Basically, it's an apocrine gland that just differentiates toward the line of being able to form, to make milk. So really, that's all an apocrine gland is. It's basically just, or all the mammary gland is. It's just a variation of an apocrine gland. It's just, it differentiates in a slightly different way. So obviously, if you see apocrine embryology, you're going to see tumors that can develop in adults or in kids that can give the apocrine differentiation in that area. So anytime you've kind of got the onlogga for that, you can actually get these lesions forming these benign adnexal neoplasms with apocrine differentiation. So this is a nipple adenoma. And notice that it looks very, very much like what we would call a papillated apocrine cystadenoma if it was anywhere else. Now, the one thing about these lesions that you do have to make sure is, because anything on the breast, you want to make 100% sure that it's not becoming cancerous. You don't want to miss a breast cancer that's arising in association or within one of these lesions. So obviously you look carefully for mitotic figures and things like that, but this lesion was totally benign and didn't have that. And, you know, it's important to not overcall things either. You know, you don't want to say, well, you know, I'm going to make sure I don't get sued and I'm going to call everything a cancer. Well, that if you call something like this a breast cancer in a woman, especially if it's a young woman, you might get sued for overdiagnosing also. So there's no easy out here. You don't get to say, well, I'm just going to call everything malignant and therefore I'm going to be safe and cover my, you know what. Well, no, that doesn't work that way. It's sort of like you have to, you know, like I always say, that it's like the three bears. It can't be too hot, too cold. It has to be just right. So you can't overcall this. You can't scare the heck out of the patient, say, oh, this could be evolving into malignancy and all this, that, and the other. You just have to know the criteria and apply it. And this is a totally benign lesion. So it's not a cancer. In contrast, this lesion, which again, unfortunately, when you get a small biopsy, it can be difficult to tell because it's difficult to evaluate and apply criteria. So this was a lesion that was taken from a larger lesion. And with any adnexal tumor, not every single any adnexal tumor, but if you get a large sort of nodular adnexal neoplasm like a hydratanoma or, basically something like this, or polymatricoma even rarely, they can sometimes undergo malignant degeneration over the course of time. It's not very common. The vast majority of them don't become malignant, but they can, like a mixed tumor, malignant mixed tumor can develop. Hydratanocarcinoma can develop, but it's relatively rare. But when you leave something alone in somebody for 50 years, 75 years, whatever, they can gradually develop little islands of cancer in them, and then they can become more serious. So you always need to make sure when you're looking at one of these, especially when they've been around a long time and when they've got this solid component, that you look for areas where there may be some atypia and mitotic figures and whatnot developing. And indeed, in this case, you can see that there is necrosis en masse here. And we can't use the architectural criteria for benign versus malignant when you've got a punch biopsy or a relatively small biopsy out of a large lesion. So basically you have to use other features. So you start seeing necrosis en masse, that's a red flag. You start seeing individual areas where there's mitoses, pleomorphic cells like you see here, that's a red flag. You see ulceration in these lesions, that's a red flag. So other areas over here, totally benign. So this is probably, we call this maybe a solid cystic hydratanoma in an area like this, or like an apocrine cystadenoma in an area like this, solid cystic adenoma. And then over here, you've got areas that look totally benign. But then you look in this area here, you've got necrotic cells, you've got some mitotic figures. So this is an example of a adenocarcinoma, an apocrine adenocarcinoma that arose in association with probably a solid cystic apocrine hydranoma. So sometimes they do develop malignancy. The good news is it's relatively rare. So just always look at these things carefully and make sure you're not missing an area like this. Okay. So then basically what will happen is somebody may have one of these things and they may notice some change in it, something like that. Biopsy it, make sure you take a good enough biopsy that you're gonna be able to pick one of these areas up if it's present in one of these lesions. Okay. Now this lesion, very common, relatively common lesion, and notice the technique here. This was taken by a enucleation technique here. So a patient comes in, they've got a subcutaneous nodule, rubbery, you feel this. These are usually, but they don't have any pain to them. We all know that there are some adnexal neoplasms that are painful. We'll talk about those in a minute, but this is not one that was painful. You think it's a cyst, you do a little incisional biopsy, pops out, and this is what you see. You see this area where there's all of this mucin here. And notice that it actually, in this case, has started undergoing cartilaginous metaplasia and even ossification here. So this is an interesting example of where you've got both chondroid differentiation, but also you've got bone formation in this lesion. And then here you've got this solid area over here with these cuboidal cells. You've got the ductal differentiation. If you look carefully, you might see a little bit of apocrine differentiation in here as well. And this is one of those entities that dermatopathologists like to sword fight about. And they fight, well, is this an equine lesion? Is it an apocrine lesion? And, to me, I know Dr. Ackerman used to say, aha, there's apocrine cells in here. I don't care if the whole rest of it looks like equine. I don't care what the enzyme studies show. I don't care what the genetic studies show. This proves that it's at least partially apocrine. And so he used to think that these lesions were all apocrine. And, I kind of agree with him. I think the vast majority of them probably are. Vast majority of most of the neoplasms we see that are sweat gland differentiation are apocrine. So I tend to agree with that, but it doesn't matter. The most important thing is recognize this is a mixed tumor of the skin. And again, I don't care if you call it an equine mixed tumor, an apocrine mixed tumor. Mainly the criteria are these cells that are cuboidal. They can be clear, they can be more basophilic. You can get areas where there are some apocrine differentiation, you get some areas where there may be zero apocrine differentiation, but then you usually get an abundant amount of mucin, and that mucin can actually ultimately lead to cartilaginous metaplasia, and in this case, actually ossification, which is relatively rare. But anytime you get abundant mucin in any lesion in the skin, I don't care if it's a pretibial myxedema, less common there, but you can see cartilaginous metaplasia whenever you get a lot of mucin. It's again most common when it's kind of associated with an epithelial component, and it's usually more epithelial mucin, but you can see it sometimes in connective tissue mucin, and that's not anything to worry about. Just basically lots of mucin turns into cartilage, and anything that turns into cartilage can eventually turn into bone, and that's actually what happened here. And you actually have a little bone marrow in here, and I think I may have mentioned this before, but there are actually been a few case reports of benign ossification and skin lesions, and then people look at the bone marrow that's in there and they find leukemia or something like that in the bone marrow. So that can happen also. It's pretty rare, but here you see the nice mucin that's become cartilaginous. Now, these lesions in dermatology, often seen head and neck area, the trunk, extremities, that sort of thing. There's an analogous lesion that occurs in the salivary gland that's known as a salivary mixed tumor or a pleomorphic adenoma. So just so you'll be aware, mixed tumor in the mucosal surface in the mouth is basically looks the same, but it's called pleomorphic adenoma. So it's the same entity basically. And when you look at those lesions, they can have apocrine morphology to them as well. You actually have myoepithelial cells there. You can stain that with a smooth muscle actin and highlight the myoepithelial cells. And in some of those cases, you can get a prominent proliferation where the majority of the cells are comprised of the epithelial component with relatively little mucinous component or relatively little cartilaginous differentiation in the lesion. Then those end up getting called monomorphic adenomas, but they're basically the salivary gland analog of what we see in a skin mixed tumor. So just be aware of that. Those lesions can rarely develop into cancer. These lesions can rarely develop into cancer as well. Obviously, make sure if you get one of these, you look at it to make sure you're not missing a cancer. But the vast majority of these, totally benign, do an incisional biopsy of it, pops out, and surprise, surprise, you're not dealing with a cyst, you're dealing with a mixed tumor of the skin. And these generally are not painful. Now, this lesion, kind of shifting gears a little bit, so we're moving away from an apocrine lesion to now what would be more characteristic of an equine lesion. So here we've got another cyst, and look at the lining here. It's lined by these very thin, probably 2 to 3 cell layers of these cuboidal cells, and this is an equine hydrocystoma, okay? Do we really know 100% for sure that it might not be a little apocrine hydrocystoma that just doesn't have a lot of apocrine snouting to it? Well, no, we really don't. But when you see these very tiny, thin layers like this, they get called an equine hydrocystoma, and I think that's reasonable. I don't like to fight about these. But this one also shows another thing that's kind of interesting. It's got this dark material in the center of it, and this is the equine sweat that probably contains a little bit of melanin in it. And it's actually got this brownish discoloration to it. And so when you see these lesions clinically, what color do you think they are? Well, they kind of almost look sort of a bluish gray color, and they very commonly get biopsied and submitted as rule-out basal cell because of that. Now, this is kind of unusual. The vast majority of them do not have this dark discoloration in here. Some of this actually may be lipofuscin pigment as opposed to being melanin, but in some cases it actually is melanin. But it's totally benign, doesn't mean anything serious, but these things can simulate melanocytic lesions clinically sometimes. They can simulate basal cell carcinomas. And if you see this brown material, don't overcall it a melanocytic lesion. Don't call it a blue nevus. Don't say this might be a melanoma, something like that. I remember years ago, I saw a patient that had one of these, and he was a very wealthy person, and we were all worried about it, and we want to make sure it wasn't melanocytic. It was just one of these hydrocystomas that had this dark material in it. So nothing to worry about, and just realize this is a variant of what you can see in a variant of a hydrocystoma sometimes. Okay, this lesion, notice low magnification, excisional biopsy. It's got this contiguity with the epidermis. And so now we're looking at kind of a spectrum. There's sort of three things, or four things, if you will, that can all give you the same type of epithelial differentiation. And this is a nice example because it kind of shows a spectrum of all of them together, if you will. So if you look at high magnification and you just look at these individual cells, and they look very, very monomorphous. They look like Attack of the Clones in Star Wars. Every single one of these things looks the same. They're little small, round, cuboidal cells without any atypia. They don't really look different from one another. There's no pleomorphism. There's usually no mitotic figures here. This is very classic for what we call poroid differentiation. And we say poroid, well, originally that comes from pore, and that came from the equine pore. And they noticed that a lot of these lesions had little ductal areas of differentiation they thought were equine differentiation in them. And so that's where the term equine poroma came from. But you can see these have these dilated blood vessels. That's very characteristically associated with these lesions. But they all have this very same type of differentiation. So you look up here in the epidermis, the areas that are contiguous to the epidermis, poroid differentiation. So we see this poroid differentiation in 4 lesions. When it's confined to the epidermis, it's kind of in situ, if you will, like in this area here, which we don't really see a lot of it here, we call that hydroacanthoma simplex. When it starts forming these extensions that go down into the dermis, like you see here, then obviously we call it an equine poroma. When it breaks off and there's no contiguity with the epidermis, so let's say we say a biopsy, we saw only this part down here, we call that dermal duct tumor. Not a very good name because it doesn't really mention the poroid component to it. So I think if you wanted to sort of think about this to kind of maybe cement it in your brain a little bit, you might call it a poroid dermal duct tumor and an equine poroma and maybe a poroid hydroacanthoma simplex. And then sometimes if we just were to see something like these dermal cells, like here on the scalp and a large nodular lesion without any contiguity to the epidermis, then it's a poroid hydratanoma. So those are the 4 entities that give you poroid differentiation. Of course, you can get malignant variants of those, call that obviously a porocarcinoma, but they all look the same. They all have that classic poroid differentiation. Here you see a little ductal differentiation over here. Okay, so that kind of goes along with it. And it's really a nice example. And when you kind of get that in your mind, you fix those together, you really won't ever you'll never miss a diagnosis, right? So they all look the same. So just think of it as the same type of differentiation. One's in situ, one goes into the dermis, kind of looks like a wart. One's got no residual epidermal involvement, and one kind of looks like a little dermal nodule or tumor. All the same basic differentiation. So those are the family of the poroid lesions, if you will. Okay. So kind of keeping with that theme, let's look at this one. So you think in your mind, here we go, we've got a dermal-based process here, and it's got higher magnification. It's got those same kind of cells. So what do we call it when it doesn't have any contiguity with the epidermis? We call it a dermal duct tumor, okay? So if it's basically a large nodule, we might call it, again, a nodular poroid hydratanoma, but basically this was a relatively superficial lesion, so we just diagnosed this as a dermal duct tumor. Same thing, same type of differentiation, just different amounts of epidermal contiguity. So that is a dermal duct tumor. Not the world's best name, There's very little ductal differentiation in here. There's, doesn't tell you what kind of differentiation is. So whoever named that, we probably should rename it. So we won't do that today, though. Okay, let's take a look at this lesion here. And just going back to those poroid lesions, the poromas, equine poromas, they most commonly occur on the volar skin, obviously. So they look like warts. They usually get submitted as warts. They often have a little moat around the periphery of them, and they can sometimes be kind of reddish and friable. Dermal duct tumor just looks like a dermal nodule. You don't really see much of anything in a hydranoma. It usually will look like kind of a cyst or something on the scalp. So those generally never get diagnosed properly. A lot of clinicians, if they're good clinicians, will put down the differential diagnosis of a poroma if it occurs on volar skin. Poromas aren't confined to volar skin, though. We see them on the trunk, extremities, so they don't have to be seen in that location. Okay, now we've got a lesion in the dermis here, and it's a punch biopsy, and it's got the little small ducts here. Notice this is basically the entire lesion here, kind of wedge shape. They punch the whole thing out, okay, which is important. Because if you just get a shave biopsy of something like this, whenever you get like a ductal neoplasm, so let's say we had a shave biopsy that just kind of sampled only these areas right here. So we got a superficial shave that just kind of gets this. Well, we have a differential diagnosis, unfortunately. So this is another example of the critical nature of using the ability of the requirement to use a geographical orientation of what we're looking at here. If we're just looking at just a little small duct like we see here, you might say, oh, gosh, this could be the surface of microcystic adnexal carcinoma, maybe even a metastatic breast carcinoma. There could be a whole lot of things. So when you see a lesion with ductal differentiation, you've left the Pandora's box open to about 5 things, and it can lead into a rabbit hole. If you got something like this, let's say like a deep shave, I'd be fine if you did a deep saucerization of this, or you got a punch, or maybe you submitted a deep shave and then sent me a picture and you showed me that this person had like 40 lesions around their eyelids. Well, we got an instant diagnosis of an equine Syringoma or just Syringoma. We don't have to worry about the possibility of MAC or desmoplastic tricho or metastatic carcinoma or any of those kind of things. So we like to make specific diagnoses and then move on to the next case. We don't like to hedge. We don't like to create rabbit holes, and we don't like to create worry. Our goal is to diminish worry in patients. We want to reassure patients. We want to make definitive answers, give the clinician a good diagnosis. They can talk to their patient about it. Boom, they move on to the next thing. So they don't have to worry about this. Well, this is a nice punch that's a small, symmetrical, well-circumscribed lesion comprised of these ducts of cells with no cytologic atypia, no mitotic figures, thickened sclerotic hyaline stroma surrounding these individual aggregations, very common. This is a classic example of a Syringoma. So we make the diagnosis here. We don't have to raise any differential diagnosis here. We can be definitive in our diagnosis, and we can move on to the next case. So this is a Syringoma, and this is the type of biopsy that we like to get, something that allows us to assess the breadth, small, symmetry, almost vertically oriented, wedge-shaped here. Those are all things that we can use to make the diagnosis. If we just look at this, microcystic adnexal carcinoma, if you just had this field alone, can look exactly like that. You don't have to have one mitotic figure, one atypical cell in microcystic adnexal carcinoma. And that's based on depth and diffuseness of the lesion, almost like a verrucous carcinoma. It's based on the extension into nerves and into deeper structures. And you get neurotropism and those things. They can be very large lesions that can spread. So again, the cytology is not the way to diagnose these various lesions. You have to use architecture plus cytology and morphology of the individual aggregations. So that's the way that you diagnose a Syringoma. So it's not Syringomatous carcinoma. It's not a microcystic adnexal carcinoma. Nothing to worry about when we get that kind of diagnosis. Is this apocrine? Is it equine? Again, everybody sort of thinks these are equine because they're smaller ducts. I don't know. They might even be apocrine. Who knows? But it doesn't make that big of a difference. The main thing is that you don't make it tough to make the diagnosis because the sample's not good. And there's no stain at all. that's going to help you there to distinguish that. You need morphology to make that diagnosis and clinical correlation. Okay, so here we've got a nodular lesion, okay, deep shave here, and it's a large nodular aggregation of these cells here. And notice that these, again, have kind of a clear staining cytoplasm, cuboidal staining cells. Anytime you see clear in a lesion like this, you should think that it's probably mostly going to be glycogen, most likely, and you've got ductal differentiation here. So this is an example of a hydratanoma. Now there's a family of hydratanomas also. We've already talked about a poroid hydratanoma. You can get clear cell hydratanomas where the majority of the cells look like these clear staining cells here. You can get a solid cystic hydratanoma. And then sometimes we just call these things nodular hydratanomas, and they're kind of not otherwise specified. This one kind of would maybe fall into that category a little bit. It's got some clear staining cells in here. It's got some cells that are maybe a little bit poroid, but it's not really super monomorphous like we see with a classic poroid lesion like those poromas I showed you before. So we'd probably just call this a nodular hydratanoma with maybe some areas of clear staining differentiation in them. It's maybe even got a little bit of a cystic component up here at the top. So again, this might be, maybe a solid cystic hydratanoma. The main thing is that it's benign, okay? And it's not malignant. And we sometimes recommend re-excision of these lesions. They're large. Again, they can undergo malignant degeneration if you leave them alone for many, many years. And they recur, and sometimes they're eroded and they ooze and some things like that. And they're often on the scalp, and patients are sort of traumatizing when they comb their hair or brush their hair. So, we often just recommend removal. Whenever that something is on the scalp and it's difficult to monitor, I don't care if it's a cellular blue nevus, if it's congenital nevus in a kid, something like that. That's one reason that a lot of clinicians say, let's just, end the story here so we don't have to watch it for the rest of your life. Let's just get rid of it. And it's logically reasonable to do that. And we're not worried about it being cancer at the time, but we're saying, let's just make life convenient and get rid of it. I had a friend of mine that had a nevus sebaceous on his cheek. I kept telling him it's benign, you have to worry about it and all this kind of stuff. Eventually, we just decided to cut it out, and he's got a great cosmetic result there, but he just decided he didn't want to keep watching it because of the theoretical chance he could develop basal cell carcinoma. It was just super rare, but now it's gone, and he can think about other things. So basically, the same thing is true with these lesions. So this is an example of a nodular hydratanoma with solid cystic areas and even some areas where there's some clear cell differentiation, but not cancer. No mitoses, no malignancy, no necrosis on moss. We're not worried about it. One thing I didn't say that I'll mention again real quick is when you see a poroid lesion, I should have said this before, but because we didn't have it on that example I showed you before, but sometimes equine poroidous lesions can give small zones of necrosis on moss. So normally you think of large areas of necrosis on moss, we think of cancer. That's a sign of malignancy. But you get small areas of little geographic, small areas, not massive areas with mitoses and all that kind of stuff where it's really tumor necrosis factor that's causing it, or ischemia. You get these little small areas where you kind of get almost like maybe 20 or 30 cells together. They all sort of necrose at the same time. That's very common in equine poromatous lesions. Doesn't mean malignant. It's almost kind of a clue that you're dealing with a poromatous lesion if you see that. So just remember that's an exception to the rule where necrosis in that case does not mean malignant. Okay, this case here, so we're going to look at this in a higher magnification and notice that it's got these individual small basophilic aggregations of cells. And notice how they're kind of almost like they're put together like a little jigsaw puzzle, if you will. Okay, so when you see this pattern, cells are kind of closely aggregated to one another, and they're not coalescent. They've got these individual pink hyaline aggregation, hyaline structure, little zones between them. So this hyaline collagen, and maybe some of that is probably some hyalinized basal membrane-like material surrounding the individual aggregations. And notice that the cells are very small and round and cuboidal, with perhaps some admixed ducts here and there. This is an example of a cylindroma. Okay, cylinders of cells. So think of these little straws, little cylinders, and they're just kind of touching one another. Think of it almost like a little bunch of straws you put together with a rubber band around them. So this is an equine cylindroma. Again, are these really equine? Are they apocrine? You can argue and fight about that all day long if you want to, but this is a nice example of where you've got these pink little sort of strands of collagen and pink hyaline material surrounding the individual aggregations, and they're really kind of almost cemented close to one another like this. Now, one other thing you'll notice about this lesion, you've also got these little pink hyaline droplets within the individual aggregations. You see that very commonly in a spiroadenoma, which we're going to talk about. That's the next one we're going to talk about. And it's not uncommon to see combinations of these lesions. So when you see areas of cylindroma plus spironoma together, you should think of the Brook Spiegler syndrome. Okay, that's a board question. So they very well might ask you, what is the Brook Spiegler syndrome? And you got to know all the various entities associated with it. I'm not going to go over those today, but please bone up on those. So this lesion's got a little bit of that here. You got a little bit of spironoma area here, coupled with the more obvious cylindromatous area. And notice the ductal differentiation here. And notice that, oh, wow, there may be some apocrine snouting. So for those people that think these are equine lesions, well, Dr. Ackerman would come out of his grave and fight you, because you say that proves that it's apocrine, because it's got the apocrine little decapitation secretion areas in it focally. I don't know if that's really true or not, but that's basically what he used as his sort of proof of concept that these really were not purely apocrine. So let's take a look at a spironoma. And the classic sort of mnemonic device for this is a blue ball or blue balls, multiple blue balls in the dermis. So blue little cannonballs in the dermis, think of spironoma. And then you got higher magnification. Of course, it's got a lot of chatter artifact in here. It looks just exactly like those little small aggregations that we saw in the cylindroma a minute ago that had little small spironomatous elements to it, the small little pink hyaline droplets in here. You may get little small areas of ductal differentiation. And again, the difference here is that usually you've got these individual small aggregations. Usually there's 2 or 3 of them, or even more than that in the dermis, but you don't really have all the little small aggregations that are kind of put together in a way, kind of like a jigsaw puzzle like you see with a cylindrome. So a lot of these you'll see kind of a combination. You'll see areas where there are classic larger blue balls in the dermis, and then you'll see smaller other areas where there's the more small aggregations with the pink hyaline cylinders surrounding them. So you'll see those together. And when you see that, again, think of the Brook Spiegler syndrome in that situation. Now, this is one of the classic painful tumors of the skin, Bingle or England or Angel or whatever mnemonic device you want to use to remember that. I think probably every first-year dermatology resident in the world learns that within the first few months of their training. So everybody knows this, and it's probably it's no fun anymore to ask questions about it because everybody knows what it is. But anyway, it's something to remember that can tell you the differences of the painful tumors. Now, one thing about the painful tumors, they don't all have to be painful, interestingly enough. We see lots of lesions submitted to us under the microscope that are just sent in as regular garden variety lipomas. So obviously that means they're probably not too painful, or the clinician would have put that down. Yet they show histologic features of an angiolipoma. So everything in that England, Bingle mnemonic, it doesn't have to always be painful. If they are painful lesions, you want to think about the mnemonic, but just realize that they don't have to be. Now, this is an example of a no-no here, okay? So we've got a shaved biopsy of a lesion. We've got a diffuse neoplasm, at least diffuse in the small specimen that we have, comprised of these little ductal aggregations of cells that are very typical in morphology. So now we do have the Pandora's box that we have to deal with. Is this a syringoma? Is it a microcystic adnexal carcinoma? Or the other name for that is syringomatous carcinoma. Is it the surface of a desmoplastic trichoepithelioma? Probably of that one, the answer is most likely no, because that one usually gives you small little cysts with calcification. So I think usually in a shaved biopsy, you can usually, when you see the areas of small cystic calcification and small little cysts and small little follicular germ structures, you can most of the time diagnose that on an inadequate shave biopsy, or you can suspect that on that situation. But here, this is the surface of a microcystic adnexal carcinoma, and you can't make this diagnosis with certainty here. So unfortunately, we can't really do it. We would suggest it. We would suspect it. We would go back and tell the clinician to take another biopsy. The only way we really were probably able to make the diagnosis here is that we really had some good clinical information. There are some clues here. So ideally, what I'd like to show you is an incisional biopsy showing that this goes really deep all the way down into the subcutaneous fat or to near the subcutaneous fat. And there is probably involvement of nerve twigs. But you can see that these are not small little ducts like we saw in the Syringoma, although you can see this pattern sometimes in Syringoma, by the way, so this doesn't rule out a Syringoma. But these are usually a little bit more solid areas. They're often kind of have these sort of almost tadpole-like extensions, but you can see that in Syringoma too. And then you can see some clear staining cells in here. You can see that in Syringoma also. And occasionally you might get a mitotic figure, which we don't really have here, that you do not see in Syringoma. But the problem is that, these are more solid and there may be a mitotic figure here. So we would certainly, if I saw this, I'm sure I didn't call this just an absolute straight out microcystic adnexal carcinoma on this biopsy because we can't really say for sure that it is. We probably called it the surface of the sclerosing epithelial neoplasm and probably suggested it could be the surface of MAC. And then they went back and excised it, and lo and behold, it was a MAC. So this is what a MAC looks like if you just look at the top of it. But we don't like to look at the top of the MAC. So whenever you see something that's white and sclerotic looking on somebody's skin, you can take a shave biopsy, but just realize that you're not getting the best evidence in the situation. You really want to you may need to go back and take a deeper punch biopsy or an incisional biopsy. And when you encounter somebody like that, probably a good idea to send a clinical photograph in. So if it's a young woman, maybe on the nose, and you say, well, yeah, no, Dr. Cockerell said we need to take a deep punch of something like this. You really don't want to do that because it's an attractive person and you don't want to cause us a bad scar. You can try to get away with this, but just realize you may have to go back and take another biopsy. And if you're going to do something where you're going to try to get away with something, send us a picture. So don't just say, I'm going to just fly by night and just do a shave and send it in, the nub, neoplasm of certain behavior without any additional information. No, don't do that. Send us a picture, give us some other information, let us know, normally I'd send you a deep biopsy, but we have extenuating circumstances here. I'm sorry, we're having to send you a shave. This could be the surface of a deep sclerosing neoplasm. Here's a picture of it. And then we can give you the best diagnosis we can under the circumstances. And then you may have to go back and take a deep biopsy anyway, but if it is a microcystic, you're going to have to go back and re-excise it. Okay, let's take a look at this. So this is a beautiful biopsy, and chances are here they probably did not do this first. So, we don't expect to get excisional biopsies. Dermatologists love the shave biopsy. That's the biopsy technique of choice. That's the technique I use when I sample most lesions to rule out basal cell and dysplastic nevus versus theoretically possible melanoma. We do a deep saucerization there. So yeah, no, I get it. We're not asking you to do excisional biopsy. So this was probably shaved, biopsy was made, and then we got this biopsy back on the excision. And notice that we've got this sea of mucin here. Sea of mucin. And floating within it, we've got these aggregations of these epithelial cells with this clear staining cytoplasm and focal areas of ductal differentiation. This is a beautiful example of a mucinous carcinoma. Now, mucinous carcinoma can occur in two different ways. There's actually now three different ways really in dermatology, but the first way is a primary way. And it's where they basically occur as a primary lesion located on the skin. And basically, this is thought to be equine differentiation. Notice it's got the nice little ductal differentiation here. These cells almost look like kind of forming little rosettes here. So this is what we call a mucinous carcinoma of equine glands in this situation. Primary lesion, no spread from the breast or anything like that. But that's the other setting. where you can see mucinous carcinoma, a metastatic mucinous carcinoma to the skin, from the breast, from the GI tract, something like that. And usually when we see that, we'll see areas that really kind of suggest the differentiation that the primary neoplasm is exhibiting at the site. So if it's like a metastatic breast carcinoma, you usually see some areas look more ductal and really look like breast carcinoma that's metastasized to the skin. And those usually have a lot more mitoses. There's usually a lot more atypia. Here you don't really see a lot of mitotic figures. You got occasional ones. You got some pleomorphic cells, but these lesions in the skin are very low grade. I mean, these lesions have 100%, they're like a basal cell, basically. You just excise them, they go away, patient lives happily ever after. You almost never get any real complications from these lesions when they occur primarily in the skin. So the main thing here is you just want to make sure you're not missing a metastatic mucinous carcinoma somewhere else. So clinical correlation, once again, here is very important. If it's been present for many, many months, years, maybe it's a man, there's no history of any kind of underlying cancer of any kind, and then you biopsy this and it comes back as mucinous carcinoma, then you can feel pretty well assured that you're dealing with that. Now, a lot of people that are stainers and love to stain things, which that's not me, and they say, well, let's do stains for, see if we can differentiate this by doing stains on it. Let's do stains for, say, androgens, or let's do estrogen and progesterone receptors, and let's do these various stains, BUR-EP2, or let's do mammoglobin, all these kind of things. Sadly enough, the equine lesions, the primary equine lesions, can often express some of those markers also. So once again, it doesn't take your need to correlate it with the clinical away. So again, beware of using a stain to solve all your problems. If you stain this and say, well, it really stains like it might be a breast cancer, and then you go work the patient up and they don't have any evidence of breast cancer, it doesn't really help you all that much. I mean, it still could be a primary lesion. And if there's a worry that it's a breast cancer, whatever, I don't care what the stains show, you're still going to want to work that up anyway. So you can stain it if you want to, but to me, again, being a dermatologist and clinician, the best way is to go back to the patient. And if there's a history of breast cancer, something like that, well, that's going to change your perspective on this. And if it's been around for 5 years, what's the chance of being metastatic breast cancer in that situation? Probably next to nothing. So again, just realize that that's the case. Now, there's one other lesion that's relatively newly described that can also give you abundant mucin, and it's mucin-producing neuroendocrine equine carcinoma. This mucin-producing equine sweat gland carcinoma that's got this neuroendocrine differentiation. And to me, that's just basically a variant of this mucinous carcinoma equine sweat glands that somebody decided a few years ago to start working up, and they did stains for neuroendocrine markers, and boom, they found that there's some positive staining with INSM1 and with synaptophysin and whatnot. And so they split it off and called it this mucinous producing equine sweat gland carcinoma. Well, the equine sweat gland business and all that stuff, the neuroendocrine sweat gland carcinoma, I don't know if it really makes a lot of difference. It sure doesn't behave like a Merkel cell. It behaves pretty much just like what we called for years the mucinous equine carcinoma. So it is an entity. It is in the literature. You do need to know about it. You do need to know that it stains positive for neuroendocrine markers, but it's not really like a Merkel cell carcinoma. It does not behave like Merkel cell. It really behaves more like a primary mucinous carcinoma of equine sweat glands that we use that name for decades. Okay. So the last one we're going to look at today is, see if I can get it to get in the middle of the screen here. Got a shave biopsy and notice that it's eroded, it's ulcerated, it's poorly differentiated. And let's go to higher magnification here. You can see that it's got these it's got some ductal differentiation. It's got some cuboidal cells in it. Over here, maybe it's poroid, but now we've got mitotic figures. We've got necrosis on moss in some of the areas. We've got some ductal differentiation. So this is an example of a poroma gone bad. So this is a porocarcinoma. Relatively rare entity. I don't use the diagnosis all that much, mainly because most of these are kind of poorly differentiated basosquamous carcinoma. So if you're really going to make this diagnosis, you really need to see areas that are pretty classic for poroid differentiation, at least in some areas, and you need to see pretty good ductal differentiation. I found that when these lesions kind of become malignant, And here you see, well, maybe was this the silhouette of a poroma at one point? You know, maybe. I find that these things sometimes end up getting overcalled. A lot of them may be sebaceous carcinomas. They may be kind of poorly differentiated basosquamous carcinomas. At the end of the day, it doesn't make a lot of difference because they pretty much all behave like a squamous cell carcinoma. They can metastasize. They can behave more aggressively. They don't behave like a melanoma, so that's the good news. But they can metastasize just like any sebaceous carcinoma or squamous cell carcinoma can metastasize. So again, if you get a squamous cell that arises from an actinic keratosis superficial, that's going to behave very non-aggressively in the vast majority of cases. If you get a squamous cell carcinoma that gets pretty big and deep and goes into the reticular dermis and subcutaneous fat, well, that's going to behave potentially aggressively, especially if that's like near the mucous membranes. If you get one of these lesions, they're going to behave more like that than they're going to behave like a basal cell. So just realize that they're not going to behave like a melanoma, but they're going to behave more like a squamous cell carcinoma. So to me, really digging deeply into whether this is a porocarcinoma, whether it might be a sebaceous carcinoma in some cases, is of less importance than just recognizing that it's not just a classic garden variety benign lesion. You've got asymmetry, you've got mitotic figures, you've got areas of necrosis, you've got ulceration. So once again, you see something like this, you know you're not dealing with a cancer. And if you want to call it a malignant hydratanoma, that's okay. If you want to call it a porocarcinoma, that's okay too. And just recognize that it's got an adenocarcinoma. I mean, that might even be a sebaceous cell. So I don't know for sure that this lesion isn't some variant of a carcinoma that's demonstrating multiple lines of differentiation here. Okay, well, that's all I've got for you this morning. Show a lot of good examples of interesting lesions. I believe we're going to be finished, at least for the year. I'm going to personally take a trip out of the state of Texas for the first time in a long time. So I'm going to put on an N95 mask and mask up and take my life in my hands and get on an airplane. But we've got the vaccine coming around the corner. I think hopefully next year we'll be able to go back to giving some live talks again. But this has been a pretty popular forum. So what I think we're probably going to do is maybe do a blended version where we show some of these kind of online lesions, lectures coupled with some live lectures again. So everybody have a great holiday. Hope you don't think too hard about dermatopathology over the holidays. Enjoy your Christmas, your Hanukkah, all your various holidays, and we will see everybody in the new year. Take care.